10 seconds. Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation, 60 minutes that could save life and limb with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by Patient Advocacy Group, the Global PAD Association at padhealth.org, in partnership with Reflow Medical, the pulse of medical ingenuity. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of the Global PAD Association, Kim McNicholas, and interventional cardiologist and founder of Save My Piggies Health and Wellness, Dr. John Phillips.
Hi, everyone, and welcome to the show. Dr. Phillips is off saving some limbs, duty calls. So Dr. Nick Patel with Ava Vascular in Murrieta, California is pinch hitting as guest host for today for a very special presentation and discussion where we are honoring a special individual who eats, sleeps, and breathes, saving life and limb for people with a disease more prevalent and deadlier than most cancers combined, known as peripheral artery disease, which is blocked arteries in mainly the legs that cause leg cramps, leg pain, and leg fatigue. He is so dedicated to improving patient outcomes that if he can't do it with the tools and techniques available, he simply invents them. That's why we are honoring today Dr. James Joy with Bay Area Vein and Vascular through the Global PAD Association's 2024 PAD Impact Awards with the Champion of Innovation Award. We are going to introduce you to him in just a moment and tell you about a now FDA-approved procedure that he invented that is increasing a physician's ability to restore blood flow to the legs and prevent amputation. But first, a big hello to my co-host for the day, Dr. Nick Patel. Hi, welcome, Dr. Patel. Thank you for being here on this Saturday.
Thank you, Kim. Honored to be here and honored to be with Dr. Joy as well and the guest audience. It's been a busy week and busy weekend now. So, things have been really great. Been really helping a lot of people with critical limb ischemia, healing wounds, and glad to be part of this community. And
Any case that stands out this week? I mean, it's a tough week for you as a CLI fighter, critical limb ischemia. That's the most advanced stage of PAD, and we call doctors like you and also Dr. Joy CLI fighters.
Yes, absolutely. It's always, we're always learning new things from patients and challenging procedures with the challenging disease. Definitely we'll share some experiences as the show goes on.
Yeah, but first, I think before we get started, how about a moment of inspiration?
Absolutely. I have a good quote from one of my favorite movies, The Shawshank Redemption. It's
Oh,
a
yeah.
1994 movie.
Good.
And the quote is Tim Robbins, who's the leading actor with Morgan Freeman. He talks about hope. And he says, hope is a good thing and maybe the best of things, and no good thing ever dies. So I want everybody out there to keep their hopes up, and we'll get through this fight. And hope is very important. So keep that in mind.
One of my biggest pet peeves is when a doctor tells me you really should not give false hope to people. And I said, it's not about giving false hope, it's giving hope. And hope helps you feel good. Hope helps you to literally just be compliant. It helps you to move forward. I think everyone deserves even a glimpse of hope, no matter what their diagnosis, because doctors like you and doctors like Joy give so many hope because you've proven that you can make the impossible possible. What some doctors say is impossible, you actually make possible. And that's amazing. I love that quote.
Thank you.
So I want to introduce you to another hope giver here in the world of limb salvage. Dr. Jim Joy. He is the Global PAD Association's Champion of Vascular Innovation for 2024. Now, this award, before we introduce him, it honors an individual who exemplifies exceptional advocacy for PAD patients, standing up for their rights and well-being, even at personal and professional expense. This champion will have made significant contributions to community building, awareness raising, and the fight against healthcare disparities. So important, all while demonstrating personal sacrifice and a measurable impact on the PAD patient community. Now, most importantly, for this particular award, this individual has made a significant impact on improving care through innovation. And because his patients this year have asked the most about a new minimally invasive bypass, we had to honor Dr. Jim Joy for that contribution and more to improving PAD care. He invented a device known as PTAB, and we're going to hear more about that over the next hour. But first, let's offer a warm welcome and congratulations to Dr. Jim Joy, Champion of Vascular Innovation for 2024. So well deserved, Dr. Joy.
Very kind of you, Kim. Yeah, I'm as is usual in a situation like this. I'm standing in front of countless people that made this happen, that helped to bring this concept to reality and ultimately get it to market. So I'm honored, I'm humbled, and I'm grateful for everybody that contributed to make this happen.
You know, so many doctors out there today, especially when it comes to limb salvage, are continuing to argue for their own limitations, saying things, can't be done, they shouldn't be done. Let's just amputate the legs because there's no procedure out there. There's no evidence for any procedure that makes it worth our while to restore blood flow to these patients. So let's just not delay the inevitable. Let's just go ahead and amputate. And I always say to them, well, you know what? Why not create the evidence? Why not help create the solutions? And here you are, creating a solution. What is it about your training, who you are with your character, that makes you not argue for your own limitations and truly live up to the practice of medicine?
Yeah, I just think at the end of the day, it has to be a very individualized approach to each patient. And there's nothing more irrevocable than an amputation. And I think for me and for others that do this type of work, you always want to help. You always want to offer some, as you mentioned, hope, some pathway forward. And a lot of times that drives innovation. And so in this situation, we're facing some of the most difficult lesions that we come across in the lower extremities. We didn't have a good solution. And now we have something really significant we can offer.
And coming up right here on the Heart of Innovation, we're going to hear the significant impact that he is having with this brand new device that he is the brainchild of. So don't go away, right here on KDOW in the Heart of Innovation.
Leg health can indicate risk for heart attack, stroke, and amputation.
Boy, that voice sounds familiar. Nice job, Colin. Okay, so Dr. Patel.
Yes, Kim.
Would you like to take us back in and kick off the conversation on PTAB?
Absolutely. So we have Dr. Joy today.
Hold on. Well, we got to wait till we come back from break.
Okay. I thought we started already.
Okay. That was a good fire drill, though. Colin's going to give you the cue. We have the commercials right now. I think it's only a couple minutes, and then we can kick off. Heads up, 1 minute, 20 seconds till we are back on air. We are still live on the web, though. So we just maintain that channel being open, and our YouTube producer, Joshua, monitors that. So we may end up with some comments or questions coming in from there. And then in studio, down in, where are you at in Colin? You're in the South Bay somewhere. I can't even remember. He's not listening.
I am over in Fremont.
Oh, he's over in Fremont, our Fremont studios. So, Douglas, do you already have a question? We haven't even started.
Yep.
Can you wait for another segment?
Yes, I can. I watched the video and I got a question.
Oh, good. So
Usually provokes a couple. Hey, Kim, if it fits going forward, Golden State Heart and Vascular versus Bay Area Vein and Vascular. Just, I mean, we still represent as that in that one office.
Sorry to interrupt. 10 seconds till we air.
the Golden State Heart and Vascular.
Yeah.
Okay, I will, for the permanent one, I'll retape
Live in 2.
after the show.
Right.
Okay, Nick, get ready.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everyone. This is Dr. Nick Patel. I'm filling in for Dr. Phillips while he's saving some legs and some lives. We have a very important and a famous guest on the show today, Dr. Joy, who's an inventor of a new device that can be utilized in patients saving legs without a knife, without an incision. So let's get to the show and let's have Dr. Joy tell us more about the invention and how what inspired him. Dr. Joy, was there a patient that you came across that led to you thinking, saying, hey, I need to do something differently. I need to see what's available out there. And you looked around and you didn't find anything. And you said, let me try this. And was it a patient scenario or was it just an idea that came to your mind that led to this invention?
Yeah, great question. So I think any of these processes, there's a number of kernels along the way that really make the final boom happen. I started doing long segment occlusion work back in the early 90s. And at the time, we had just discovered some newer techniques to get through these long blockages without opening the patient's leg up. We had some really prehistoric stents that we were using to, make this beautiful result when we finished. But the reality was, and this is a reality, unfortunately, that's persisted despite stent generations of development since, that these long segment stents just continue to close, and we're tasked with reopening, and it's a kind of a fruitless venture. And then a number of years later, as I was involved in a different technology as an advisor, and I was kind of the junior guy in the room, kind of the guy they sat in the corner, and we were trying to invent a way to do coronary artery bypass surgery without surgery. And this was a technique that failed miserably. It just couldn't be done. But the idea behind it sparked in my mind, why are we wasting our time trying to do this in the coronary arteries when we have this large format, big problem in the lower extremities that we could easily apply it to? And at the time there was, nobody was really interested in that because, the heart was where where the excitement was. And I was a cardiologist that was spending more and more of my time in the vascular world. And I said, you know what, I'm just going to do this on my own. And, if they don't want to pursue it, great. I'll just see where it takes me.
So how did you even get started with it? So you're a doctor, you have an idea. What does it mean for you to go to the drawing board?
Yeah, literally started on the drawing board, Kim. Lab notebook, lots of pictures of anatomy. I'm drawing, asking a lot of my colleagues questions about what they encounter in open surgery, looking at the equipment that was on the wall, things that were already commercially available. How could I modify these to do what I wanted to do? And then it went through everything from cadavers to animals to, lots of engineering apparatus, models, so on and so forth. And over the course of time, just refined and refined and refined. And here we are.
It always starts with these off-the-shelf items. And I'm curious what your off-the-shelf look like and what tools were involved in your makeshift model before it became the actual P-tab or detour bypass system that was, in the box.
Yeah, in the box at the time was pretty meager. We had stents, we had stent grafts, we had catheters, we had wires, we had all those things, but we didn't have the tools that were necessary to, release on, on the public physician and say, all right, here's a kit, go and do this. And so I did probably 50 plus patients with this kind of MacGyvered approach. And I'm sure that the cath lab staff, if they were on the line, would say that it was painful because they were long procedures. It required a lot of calisthenics. Patients were being flipped from their stomach to their back to this and the other thing. We had to come at it from both different directions. It just was not a toolkit available. But from kind of trudging through that and suffering through those limitations, that's where the sparks came that said, all right, what if we had a device that did this? What if we had a device that did that? How do we need to redesign a stent graft so that it has the proper strength and flexibility and so on and so forth to deliver the blood to the target downstream?
So how does the PTAB, so it's called PTAB.
Yeah.
So talk about how you went from this makeshift model to a system, the detour bypass system in the box, and you got through the FDA process. Talk about what it is and how it works.
Yeah, we used to call it PQ bypass. That was the original company. PQ was just a cute play on words for percutaneous. PTAB is a bit of a mouthful. It's percutaneous transluminal arterial bypass, so hence PTAB. I've been working on this in one form or another for 20 years, either conceptually, in cadavers, in animals, et cetera. I have had a very unusual tourism of the medical globe. We've worked in everywhere from New Zealand to Germany to Latvia to Poland to, you name the country. We did a lot of testing outside of the United States to refine it and prove to the FDA that, when we came to them with a clinical trial, it was going to be worth doing. And what we've done in this procedure is basically taken advantage of our God-given anatomy. So in the lower extremities and throughout the body, there are arteries that are right next to the veins. And in the case of the leg, there's a huge femoral vein right next to the superficial femoral artery, which is the primary target that we're going after. So when that artery is closed, currently we kind of tunnel through the inside of that artery, and we might try to clean it out and dilate it and put some stents in there and so on, but the vessel is already dead. And so we're trying to do CPR on a vessel that has already shown itself that it doesn't want to carry blood anymore. And if you're working within those confines, there's just a tremendous amount of extrinsic compression that kind of wants to close that vessel again. And added to that is these vessels are highly inflammatory in how they respond to the trauma of treatment. So surgical bypass has been done for years. It's an open procedure. It's typically done with general anesthesia and incisions on the leg, and it's been very effective, but it's a lot to go through. And so the whole concept here was to use that femoral vein that sits right next to our vessel that's closed as a conduit. So we can basically punch from the artery into the vein, run down the vein, which is a wide open hose, re-enter the artery downstream where it reconstitutes, and then span that space with a stent graft that is capable of carrying normal amounts of blood flow to the lower extremities.
And we're watching, if you're on youtube.com/the way to my heart, you can actually see an animation that we are showing, to those that are tuning in via YouTube. If you are listening right now on KDOW, you can also even check it out later. If you go to youtube.com/the way to my heart, you can see the animation whereby they're showing how the doctor can take a tool and go from the artery to the vein, hijack that vein, send a covered stent through it to reroute blood flow around a blockage. And how far can you go? I know initially that we were talking just from, let's say, the proximal part of the SFA or the superficial femoral artery in the thigh to just above the knee. But when I went, I actually had the opportunity yesterday to go and watch one of your procedures. You were sending that blood flow clear into the calf.
Yeah, correct. We originally started as going from basically the groin to just above the knee. The reality is the disease is not that discrete at all times. In fact, the patients that we really want to help go more distally. So now we've got grafts going all the way down into the small tibial vessels below the knee.
Mm-hmm. That's amazing. Well, coming up right here on the Heart of Innovation, we have some questions already coming in from our live studio audience of patients. So don't go away. You're going to hear more about this device that hijacks your vein to reroute blood flow around artery blockages in the legs. So don't go away.
3 years ago, my symptoms started with leg pain.
Fantastic. This is great. I'm really excited. Dr. Patel,
Mhm.
do you
Yes.
want to take us back and then say, hey, we want to get to some questions right away from our live studio audience. We're talking about PTAB, this, and then kind of summarize the system. And then it looks like call on Douglas first. And then once Douglas asks the question, Dr. Joy will answer it, and then call on Marcia.
Okay. We'll do that.
Is that okay?
Yep, absolutely.
And you can just remind them, just say, go ahead and unmute and ask Dr. Joy your question.
Okay.
Awesome. This is perfect. I'm going to be curious though, Dr. Joy, in terms of, I found a video when I was looking up this video, and they were starting to talk about, the challenges for this particular system. And there were a couple of doctors, of course, vascular surgeons, that were saying that they don't understand why, you would use this versus just going ahead and doing, a general bypass with newer techniques. And
Yeah,
so
I'd love to respond to that.
yeah. It's just so many of these patients that, and I think I even talked to Dr. Patel about this yesterday as well, that there are so many patients that they end up with these bypasses that they're diabetic patients. They just don't heal well. I mean, even if they get that blood flow, they just do not have the ability to heal. So you really want to minimize any sort of cuts that you do on these patients.
Yeah, the
And
morbidity in these folks is almost 30% with an open bypass. If you add in having to redo the graft, failure of the graft, infections, lymphoseals, etc. I mean, it was one of the benchmarks that we took to the FDA as in terms of our safety outcome, our safety endpoint goal. We obviously were able to blow it away in comparison to a surgical comparator. If we ever did a head-to-head trial, it would be embarrassing. I mean, the reality of how a patient goes through an open bypass surgery and what they experience. The good ones that get through bypasses can last a long time. The good surgeons that do great bypasses, good job. But kind of just the general population, that's not the reality.
no, especially the ones that have, why we're seeing a PAD epidemic right now. I mean, you have the chronic kidney disease patients and you have the diabetics, and especially in both cases, that's why we're seeing a real influx in PAD cases right now, is because the influx of those patients, and those patients are inherently, they're not necessarily good
Heads
surgical
up, 10
candidates.
seconds till we air.
Correct.
Okay. Go ahead, Dr. Patel. I'm going to leave it to you. So I'll let you get the cue from Colin, and we'll get to the patient
1220
questions.
KDOW. Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. This is Dr. Nick Patel from Marietta and Vista, California, from AVA Vascular. I'm filling in for Dr. Phillips today, who's still out there saving some legs, working long day, long weekend. And we have a very famous host for us here, Dr. Joy, who's an inventor of a new device called PTAB, which is a percutaneous bypass performed in patients with PAD and critical limb ischemia. This can be done without a scalpel, without an incision. So it's a great device. I have a couple of hands up in the audience. I have Douglas, you have a question already. If you can unmute and ask your question to Dr. Joy.
Yes, sir. Congratulations. Well deserved. I watched your video twice. Now, a plumber just puts the snake in and it goes through. You know what I mean? But how nerve-wracking is it to take these such a small minute and to have to maneuver them in the places that you do place them?
Yeah, that's a great analogy. So early on in the development, that was a big challenge that we had to overcome. And the way that we simplified it is we aren't just coming through the artery heading from the top down. The other part of the procedure involves putting a little IV basically into the vein in the lower leg. So we can come up from below from the ankle. And that way we have we have a catheter in the artery, and we have a catheter from the opposite direction in the vein, so that once we pass our needle through the artery into the vein and pass the wire into the vein, we can basically snare that wire and pull it out the other end, and we can control it from both ends, and that allows us to navigate through the veins, the valves in the veins of the leg, and safely deliver the technology. So if it were just as you described, where we're kind of blindly going down the leg, it would be difficult to impossible. But by controlling both of the conduits, the artery and the vein at the same time, then we've been able to do this much simpler.
Thank you.
You bet.
All right, we have another question from the audience. Marcia, if you can unmute and ask your question to Dr. Joy.
Thank you very much. And congratulations, Dr. Joy.
Thank you.
I'm a fellow Ohioan, and I also attended OU.
All right.
So we have some things in common. I'm in Dayton. My question is, I have a full metal jacket in my right SFA, and that, the whole thing is reoccluded. So I have a pretty strong collateral network, which is, what how I'm getting blood flow. But at some point, this might be something that I would look at in the future. The problem is, and my question is that I was sent to a vascular surgeon who ordered a vein study, and my vein was not suitable for a bypass. So I'm wondering if you have small veins or problems with your veins. Mine was just small, I guess. And so they didn't want to use it. But so how would that play with a PTAB?
Yeah, great question. And I grew up in Delaware, not far from you. So that's a real common situation where people like yourself who might benefit from an open bypass just don't have the vein to do the job. And that leaves you with an option of a prosthetic bypass, which surgeons generally try to not do if they can help it because they're not as durable. I think the good news for you is that your collaterals are doing the job right now. So if you're able to do most of what you want to do, I would say keep walking, keep building those collaterals. When those collaterals fail, though, and you become limited and frustrated with your abilities to do what you want to do, PTAB might be an option for you. And I've treated a number of patients now who had full metal jackets, like you described, stents from top to bottom, some of whom I'm guilty of as well. But the PTAB device actually can go through the side wall of those stents and still be performed. And the vein that we use for the PTAB procedure is not the same vein that was being scanned for your bypass. Oh. They were looking at superficial veins that they would remove to create the bypass. This is the deep vein. This is the large vein in the center of your leg. And I have yet to see a patient that doesn't have a very robust femoral vein that can be used for this procedure.
One follow-up, thank you very much. What if at some point something would happen to my heart and they can't borrow that vein? Like, I mean, are you kind of playing Russian roulette with the bypass?
No, that's a great question, and it's a common question, and it's also I think a dated conception that is put out there by physicians sometimes. If the veins in your legs are not good enough for a bypass in your leg, why in the hell would you want to use it for your heart? All right. So thankfully, 95% of the time, we can now take care of coronary problems with stents. We don't have to rely on vein bypasses anymore. So I don't worry about the vein that we're using for this particular procedure, again, is not harvested for bypass for the heart. And again, the heart can usually be taken care of without bypass these days.
Thank you very much.
Well,
I
coming
just
up right
want-
here on the Heart of Innovation, we're going to have more with Dr. Jim Joy. We're going to hear some of the resistance that he's faced in bringing this to market. I thought Marcia did a really good job of bringing that healthy dose of skepticism in there as well. But we're going to hear more of it, and we're going to hear what Dr. Joy has to say next, right here on the Heart of Innovation and KDOW. Don't go away. And it sounds like Dr. Patel might have a question in there. So Dr. Patel, you want to bring us back and then lead us into that question that you have?
Sure, I can do that. Yep.
Okay. And we can get into this is that is really interesting because that was one of the things that they were talking about. Well, my question, one of the more specific things that one of the doctors was saying was with newer bypass techniques where you don't even have to harvest a vein from the other leg, you can actually go in and you can just in the same leg, you can just instead of using the percutaneous way, you can just actually do the bypass right there in the same leg with that vein and just do a full bypass with a little cut at the top, a little cut at the bottom.
Not very many little cuts out there though.
And the other one just rings.
Okay. Hey, Colin.
I'll come in here and talk.
I'm guessing the numbers are not being answered. I'm getting message.
888 is not being answered, and the other takes you into some kind of a buy-in type.
Oh, I might have put in the wrong number. Let me just double check.
But I can do it in here.
This segment, what are we in, Colin? Are we in segment 4? And so that's 7 minutes. Okay, so segment 4, 7 minutes. How long till we're back? Can we check the number that you have?
Didn't bring my phone here. An 800 and 888.
2 minutes, 30 seconds. Okay. Sorry, guys. Give me 1 sec.
There.
I'm going to type in the number.
The second number is a buy-in for timeshare or something.
1-800-526. Colin, is that number right? 1-800-526-1220? Okay, try that number again.
Looks like same 516.
We have 526. See. Oh, he says 516. Oh, you put 526. There we go. Right. Okay. So that should work. Colin, are you selling timeshares in your off time? Are you trying to send all of our patients over there to buy timeshares? Are you getting a little kickback?
I would never send anyone anywhere to get timeshares. I am someone who believes you should be at home, rested and well.
Walking as much as possible.
Hey, come on. You got to be like Saturday Night Live. Just strut. Staying alive, staying alive.
Hey, Colin, do you want to jump in on the next one? But you got to beat me to the punch if you want to do the tease to the break.
I can jump in on the next one. I got the parts for it to do the tease. Also, just to give everyone a heads up, we have about 33 seconds till we come back on radio.
Okay, perfect. And this
also,
is our
Kim, this is strictly for you. You actually got us out a little bit earlier than I expected, so we have some extra time slided in. So next segment is 8 minutes.
Oh, we like that. We like more time. I just knew that if we didn't get out at that point, then we were going to end up going over. So I'm
All
glad.
right, got 10 seconds and I got a phone. Give me a second.
Okay, Dr. Patel, get ready.
Okay.
AM 1220 KDOW.
All right, everyone. Welcome back to the
Heart
show.
of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone. Welcome back to the show. This is Dr. Nick Patel filling in for Dr. Phillips. We have a very important, famous guest with us today, Dr. Joy. And we were just going through some questions asked by Marcia about whether we can use the veins, that are used for bypasses. Would that be a contraindication for this procedure? And Dr. Joy explained that these are different veins. These are deeper veins compared to the superficial veins. And long as your deep veins are open, meaning there's no blood clots, I think you would be a candidate for these procedures. Dr. Joy, would you want to expand on that? Patients with DVT, would they be a candidate for this procedure?
Yeah, that's in the trial that led to the approval of the procedure. Patients with prior DVT were excluded, and that makes sense when you're in clinical trial mode. In the real world, case by case, I think you have to make decisions that are best for each patient. And so many people who have a history of DVT or a blood clot in the leg, which can affect the femoral vein, will recanalize, meaning that the blood clot will dissolve, and then you have a highway that you can utilize for this procedure. And so for those patients, as long as their limb is not massively swollen as a result of damage from the DVT, they certainly can be candidates. One of the first procedures that I did after this was commercially released was a local farmer who was just unable to maintain his farm because he was so limited in his walking ability. He had had a previous DVT. His right femoral vein was completely closed. And at the same time, he had complete closure of his superficial femoral and popliteal arteries. So he was kind of a double whammy where he had a swollen leg and he couldn't walk very far, and he was just frustrated, 73, 72-year-old guy. And after evaluating him, we found that, this was kind of a way to, expand our offerings. I was able to travel through a venous collateral, which was well-developed and went around the DVT and arrive at the same destination that we needed to, that allowed us to perform the bypass, restore the arterial blood flow. His femoral vein was already closed. He had other collaterals that were healthy. And so borrowing that one collateral allowed us to do the procedure and still not impact his venous health as well.
So I'm curious some of the resistance that you may have faced. We had world-renowned interventional cardiologist that you know well, one of your buddies, Dr. Craig Walker, on recently. You said, today with all the minimally invasive tools and techniques, there's probably not a blockage that you can't really get through these days with some of the more advanced tools and techniques that are available, number one. But then you have vascular surgeons, on the other hand, that say, well, why is this type of percutaneous bypass needed, the minimally invasive bypass needed, when we could just do a regular bypass? What do you have to say to some of those additional healthy doses of skepticism for the PTAB?
Yeah, so I mean, some degree of cross-discipline friction is good, kind of keep each other in check. But as is the case with any new technology, there are, some people just have a knee-jerk reaction that they're reluctant to change, especially if they've been doing it a certain way for 20, 30 years, and they know how to do only that one thing. There's a lot of, in this business, there's a lot of, if I can't do it, it can't be done, that we hear. So resistance is not unusual. I mean, we faced the same resistance when we started to do aortic valve replacements through a catheter, when we started to do aneurysm repairs through a catheter. Early on, resistance. They don't want to give up the golden goose. They don't believe the data. They haven't done it themselves. They have to do their own personal trial to see if it's going to work. Some of the more valid pushback or questions. I mean, the first thing that they think about is, well, how can you possibly put a stent graft inside this femoral vein? The patients are all going to have DVTs and blood clots in their lungs, and they're going to die. And that's hysteria, and it's wrong. In the clinical trials that was done, we had 0 PEs. We had classified as 1% of the cases out of 200 and some cases had a, quote, clot in their leg. And that fear has been debunked. Then you get to, well, how can this possibly work as good as a bypass? Well, I would argue that it works far better than a bypass because we don't have to interrupt the skin. We don't cut the skin. We don't introduce open wounds for infection. We don't interrupt the lymph system to create lymphoceles. And we don't have to sew the graft onto the artery, which creates inflammation. The graft is simply placed in there and gently dilated and immediately starts to work. So there's always going to be pushback and criticism, and part of the job in bringing stuff to market is you've got to have some pretty thick skin. I've lectured to crowds of vascular surgeons, the old guard, and they were just lined up in the front row waiting for the Q&A part so that they could start launching the missiles. But if you just have a civil conversation and you talk through the physiology and the anatomy and the reality of the data is unbelievable.
There. Yeah. And, before we go to break, I just we do have a very special caller that just wants to sing your praises. It's someone who's very special to me as well, who's decided to call in. My dad, whom you've saved multiple times. He just wanted to give you a shout out. Dad, go ahead and jump in. Dr. Joy is on the line here. We don't hear him. I can actually hear him. What's funny is I can hear him in the other room, but we can't hear him on here. So maybe go ahead, Colin. Okay. Well,
That's odd. He's live and strong on this side. I hear him on the radio and everything.
Well, that's amazing. Well, I'm glad that you can hear him on the radio. Is he still talking?
Went silent as a mute.
Well,
nice of him to chime in.
Yeah, definitely. We'll try and get him on in just a moment. But I just wanted to, before we go to break, Dr. Joy, with these types of new devices, you're always learning. And even yesterday, when I was observing the case, you learned something. You actually learned a couple things yesterday. You learned that you could actually go through a bypass graft, not just a stent. And you learned a little something about some complications that occur there and how to rectify those. Would you mind just summarizing your learnings from even just yesterday?
Yeah.
Well, hold on. Before we get to that, we have to go to break, and we will learn more about the struggles doctors face in treating blocked arteries in the leg. And also, Kim and Dr. Patel will continue their conversation with interventional cardiologist and limb-saving device inventor, Dr. Jim Joy, in just a moment. Please do not go anywhere. We will be right back here on AM 1220 KDOW.
Colin, is there any way we can solve these issues technically? Because the last time that we couldn't hear, the radio wasn't hearing either. And then also, can we fix it before you put it up? Fix all and take all of that out before you put up the podcast after? Possibly. I think he's trying to solve problems. Sorry about that, Dr. Joy.
No worries.
So, there's always technical difficulties.
I do.
Is what it is. He can fix the flubs, the moments where the audio wasn't coming in. Yeah, I want to figure out, because we had the audio from that video the last time. We were able to hear it on our end. But the point is, so Dr. Joy couldn't respond to what was being said if he couldn't hear my dad. So that was also kind of a moot point.
He'll get a chance later.
Yeah, we'll make it. He'll go put on he'll come in and he really wants to say something publicly for you, because you really have not, you've changed his life, like no joke. You've saved my dad, and it means the world to me, because after losing my mom 2 years ago, I wish I would have had my mom in your hands, way back when, because I don't think we would have lost her if I would have brought her to you, because you and Nima Patel actually are really thorough in your examinations. So we'll get you on in just a few moments. We only have a few moments left in the actual show, but then we'll get you on and I'll edit it in.
Okay.
So
When do you want me to go back in here, try to call in again or what?
no, we can't have you call in because of the I don't know, whatever technical difficulty that we have with the other.
Right. Yeah, whenever you
So
want me to stay here.
no, you can go out and then just come back in about 10 minutes and put on.
Okay. All right. You want me to criticize him and tell him how bad he is?
Yeah, he says you want him to criticize you and tell you how bad you are.
Keep me humble.
Absolutely not. And anyway, I have to go back. I have to and Colin, if we can retape my intro before you go away today for the podcast, so that I can make sure it's Golden State Heart and Vascular. Okay, he says will do. You're being awfully shy today, Colin. So we'll come. Oh, there he is. He's unmuting.
Oh no, I'm not shy. I just have to
I called you out.
record the segments, so I can't just be talking over them.
Okay. So we'll go ahead and we'll delete all that. Just go to break, and then we'll come back and I'll re-ask the question.
Copy that. As of right now, we'll have about 30 seconds till we are on air. This will be the final segment as well. As soon as you hear the music, 30 seconds to get out. Okay. And so Dr. Joy, we're just going to, just go through really, what you experienced yesterday, how it's, with a device, you're always learning and growing. And after it's approved, a lot of times you learn more about its potential than you could before. And then we'll talk about, maybe Dr. Patel, maybe the final question is, how do you see this technology evolving?
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kim McNicholas and interventional cardiologist Dr. John Phillips.
Hi, everyone, and welcome back to the show. We only have a couple more minutes here. We're talking to Dr. Jim Joy at Golden State Heart and Vascular in the San Francisco Bay Area, and we're talking about this now FDA-approved device to provide a minimally invasive bypass procedure whereby a doctor can hijack a vein in the leg to reroute blood flow around a blockage in a leg artery. And Dr. Joy, I'm curious, this is something, once you get the FDA approval, you're always learning and growing. And yesterday when I was in a procedure, you actually learned something new that you had never done before. Would you mind talking about how you can now use this device differently than you may have thought?
Yeah, absolutely. It's true of any new technology. When you kind of get unshackled from the limitations of a very rigid clinical trial and you start to practice real world medicine, then you start to really understand what the true potential might be. And the case in question from yesterday was a patient who had a prior bypass surgery that had failed, had prior stents in the leg that had failed, and was unable to sleep through the night because her leg would wake her up in the middle of the night. She'd have to get up and dangle just to wake the leg up. So when we started her procedure, my intent was to go into the native artery, into the old stents, and to use that as our launch pad to do the procedure. As it turns out, the wire and catheter chose to go into the old bypass instead. And we hadn't done this before, but it was like, well, the bypass and the artery are both right next to the vein. why not just use that as a starting point? And we did successfully. But one thing we know about bypass grafts that have been closed is they're basically full of clot, or something similar to it. And so in the course of doing the procedure, there's a lot of in and out, transitioning of catheters. Some of that clot got liberated. After we had completed a perfect bypass, some of that clot went downstream, and then we had to use some of the techniques we use routinely to remove the clot, restore the flow. And, in the end, everything was perfect. But, a little curveball along the way that going forward, I'll be able to advise people that we train in this device, hey, if you decide to do this, watch out for this.
Which is good. And
Yeah.
Dr. Patel?
Yeah, so I see that you're inventing new techniques as your device is getting implemented in the clinical space. Have you thought about any other ways to use this device in a different way, in a setting where we can actually go down and treat the tibial vessels in these patients with diabetes, because that's where a majority of their disease is?
Yeah.
I'm sure you must have a thought and idea about the next step in innovating this device into different use.
Yeah, I mean, for me right now, that's kind of the fun part, is exploring what its full capacity might be. I remember giving a lecture at a meeting once, and one of my friends, a great vascular surgeon, John Matsumura, came up to me afterwards, and he said, "Keep going." He said, "Keep going." And what his message was don't stop with the FemPop, explore further. And so, yes, I do believe that this is, we're already using this to bypass into the proximal tibial arteries. With smaller grafts, with different tooling, we will be able to attack those, those below knee targets on a regular basis. And heading the other direction, up towards the aortoiliac space, that may be a possibility someday as well.
Fantastic. Thank you so much, Dr. James Joy with the Golden State Heart and Vascular. We really appreciate you being here. Congratulations on the Global PAD Association's 2024 Global PAD Impact Award, Champion of Vascular Innovation for 2024. We really appreciate you being here. Thank you for all you do to save life and limb.
Thank you, Kim. Same to you.
I'm guessing that we are clear. I'm hoping that we are clear. We've kind of lost communication again on the KDOW side. I'm not sure what's going on, but we can go ahead if you guys have still a few more minutes. I wanted to get some of the other questions we had. We have Douglas, who had another question. Do you ever see this potentially being an option to prevent an axillary bifemoral bypass?
It's been a thought process. I think there's work that would need to be done. Ax bifem is something that I don't refer people for ever. Maybe once, twice in my career. Usually because we can retool and get through the aortoiliac occlusions all the way up to the kidneys, in certain cases. So Ax bifem is usually done because somebody in the area doesn't do really aggressive long segment CTO aortoiliac work.
Yep, we've seen it. You'd be surprised how many times it actually occurs here in the States. It's actually surprisingly less likely over in Europe to do it, because they consider it palliative care when they perform it, or get your affairs in order, because it has a very high morbidity rate. But number two is they'll use it if, let's say, there's an aortic infection and they just need to buy some time, clear that infection, and then they can end up bypassing the bypass later. But we're seeing so many of these that are coming our way with the Leg Saver hotline, where within months it's just failing and patients just have no option. And we're able to get them to an advanced limb saver CTO specialist, such as yourself or Dr. Patel, who can actually bypass the bypass and get through those really, really tough occlusions. But we do have, actually, before we move forward, I have a few questions for both you and Dr. Patel. But I know my dad has been waiting. He really wants to share with everybody the amazing work that you have done, Dr. Joy, to save his life. Come on up here.
Good morning, Dr. Joy.
Good morning.
Good morning. Good morning. Between my daughter and you, I guess I'm standing here. Somehow.
More so her.
Anyhow, what the first one was that I had another source did an ultrasound on me and found clots in the femoral veins and said they were occult and was going to get Eliquis to me in a couple of days from a pharmacy. And she immediately called you and you said basically have my butt in there the next morning. And you did your ultrasound, and on the next morning, bright and early, you were in putting a filter in. And thank God you put the filter in. As you told me, or Dina told me, that when they took the filter out, that I'd either be dead, heart attack, or stroke. So I owe that to you and Kim. And within a month, because I'd had shortness of breath for, God, almost 10 months, and the Thursday before she called you, I couldn't walk up 3 stairs, and she's getting ready to take me to the emergency room on Sunday, and she picked the phone up and called you, and you said get his butt in here first thing in the morning. And on Tuesday morning, you had me in surgery and found out I had 2 blood clots completely sealed in the subarteries of the RCA. So that's the second time around. And when I come out of the anesthesia, I was breathing, no shortness of breath. And I just want to say thank you. And we'll see you next Wednesday for venal ablation.
Yep.
All right. You're very welcome.
Yeah, thank you from the bottom of my heart for having, my dad here and being able to save his life, save his limbs. So he wanted to make sure he heard you were coming on today, and he wanted everyone to know that you are his hero and also my hero as well. So we really, really appreciate you so much. Okay, so are you guys ready for the speed round of the toughest of toughest questions?
Absolutely.
And this is going to be for both of you. So we have a series. It's called Journey to Diagnosis, because one of the biggest issues with PAD is the fact that the majority of patients that are presenting with textbook symptoms, in fact, more than 70% of them, are misdiagnosed with leg pain, leg fatigue, leg cramps. And the top misdiagnoses include diabetic neuropathy, they include gout, they include arthritis, they include fibromyalgia, and even back or sciatica problems. And I'm curious, you had to have had quite a few patients yourself that you're thinking, oh my God, how is it possible that this patient presenting with textbook symptoms could have been misdiagnosed and didn't get to me sooner? It could even include maybe a patient that had a spinal fusion in which, well, maybe it might have been needed for the back, but it didn't relieve the symptoms. If only that patient was diagnosed with PAD, they might have gotten to me sooner. So we'll start with you, Dr. Joy.
Yeah, this is more common than I wish it was. When it comes to back issues, spinal stenosis, lumbar disc disease, there are some subtle similarities between PAD and that problem, but with the proper questioning of a patient, proper exam of a patient, usually can clarify that pretty clearly. I think the one that you didn't mention that I see also not infrequently is somebody comes in with hip and buttocks claudication, and they've had a hip replacement and they got no better. And the problem was the person who did their initial evaluation did not appreciate their pulses, and they had iliac occlusion or stenosis. That was the cause of their hip and buttocks claudication, not osteoarthritis of the hip. So they got a brand new hip, but they didn't get better because it was a vascular problem all along.
Wow. And Dr. Patel?
Yeah, like Dr. Joyce said, this is a very common issue that we see in our practice. One patient that comes to mind is a patient who had arthritis of the knee, and I offer some minimally invasive treatment for arthritis of the knee called genicular artery embolization, GAE. It's a minimally invasive procedure without having a knee replacement. So this patient had gone to pain management and had multiple injections, in the knee with steroids and gel and things like that. And she was not getting better. So then she was referred to me for GAE. And then when I examined her, definitely her pulses were weak. Did an ultrasound, which showed her popliteal artery occluded and the tibials occluded. So I did an angiogram in anticipation for opening of the blood vessels, as well as to treat her knee, if the vessels were open. And like I expected, she had significant PAD, critical limb ischemia. Her pain in the knee was, predominantly from ischemia rather than arthritis. So we were able to, get her in, treat her, and it was just strictly PAD related rather than knee pain. And here we are, this patient's been struggling with knee pain for years, getting injections without any benefits. So.
Wow. That's another good story, but sad story, but good that they got to you. Okay, our other series is called The Pulse, and it is a case in which you learned a very valuable lesson and a lesson that others can learn from. It could be a case in which it was a success. It could have been a case that was a failure, but it had to have been a case that there was a significant lesson learned that others can learn from. So Dr. Joy, we'll start again with you.
Well, that's I could cast a broad net on this one. As it pertains to the procedures that we're doing, I think I'd harken back to one that I mentioned earlier, which was a patient that had a deep vein thrombosis and occlusion of their femoral vein. And the trial and error that I went through to try to find a venous collateral that would get me where I needed to get to was a great learning experience. What visually looked like might be the best path to get through to get to the top of the leg turned out to not be. And the things that I had to do along the way included actually dilating the venous collateral so that when the graft went inside of it, it would have adequate room to expand. And so that whole process, it's a little more technical, but if you're going through a venous collateral, you're not taking a straight shot alongside the artery. And so that collateral swings off to the side and it takes up a lot more real estate. So we had to place a significantly more grafts than we ever have before. And you had to be very mindful about the amount of overlap in those grafts, because motion that occurs when the patient starts walking again can cause them to separate a little bit. So there was a lot of learning in that case.
Wow, it's a good case. Can you also share one, even the one, again, that we talked about with the bypass yesterday, but explain, in it, because others who are watching this particular segment will separate it into two. They will not have heard our entire dissertation about an explanation about PTAB, but I think that would be a good one we can separate, and we can actually put it up so that those who are searching on YouTube and are doing the PTAB might end up finding that particular video.
You mean the bypass case from yesterday? Mm-hmm. Yeah. So in that situation, as mentioned during the show, patient had previous stents placed, full metal jacket, as was described earlier. Those had failed. Patient had a FemPop bypass that had failed. And so we were going into it with the intent of doing a PTAB from the artery to the vein like we normally do. And the path of least resistance as we entered into it was into the bypass. And so that became our starting point. And that was a new approach. And ultimately it was a successful approach. But the learning that occurred during that case was, you also have to be mindful of the fact that that bypass is full of clot. And so in the course of transiting through there and delivering grafts and catheters and balloons and so on, even though the bypass was created successfully, a blood clot went down the bypass and lodged in the distal popliteal artery. So we had to go chase after that with thrombectomy, aspiration, a little thrombolytic successfully. But it was another learning experience where if you're going to do the bypass and start off of a pre-existing bypass, you probably need to be mindful of that possibility.
Thank you. And Dr. Patel, your
Yeah,
case?
so my case, actually several cases, but concise into one learning experience. I went to one of the meetings one day, and one of the podiatrists stood up and said that the CLI fighters, we tend to open up circulation based on the angiosome, or now some people call it wound zone distribution, to help the wound heal in these patients with critical limb ischemia. And we target those vessels where the wound is. But the important thing is that, he said that, you open up one vessel, you stabilize the wound. What he meant was there are 3 tibial vessels in the leg. And you open up one that goes to the wound, you stabilize the wound. You open up the second one, the wound starts healing. And you open the third one, you make the patient walk. And that kind of really stuck to me. And every time I do these interventions, I don't stop at opening one blood vessel. I try to open all of them. And that takes time and, and dedication. And I think it's important to do that, because ultimately you want these patients to walk to prevent these wounds coming in again and improve their overall health by walking. So, and I have seen the results of treating these patients, opening all these blood vessels. I've seen patients who come into the office with a walker or a cane or a wheelchair. And then when you intervene and you open up that pedal loop and open up all the tibial vessels, you can see the change in their life. I mean, their mood gets better. They're more happier. The leg is warmer, more strength in their leg. They're able to stand, improve their balance. And some of them have also, lost their cane and walker and wheelchair and walking. So that's a big learning in my career, that you got to go and do everything you can to normalize these patients so they can have a normal life.
It's interesting because I still have so many doctors that will refuse to treat the pedal loop in the foot. They'll turn on the faucet. They won't fix the plumbing below. So the plumbing below can't support the additional flow from the faucet being turned on above the knee. And these patients just sit there in pain and they're suffering. And the doctor's telling them to go walk, walk, walk. You don't have a wound. So there's no reason to open up, no indication to open up any of the vessels below. And they'll even say, the patient says, hey, I have tingling, I have numbness. I mean, I have neuropathy in my foot. I have burning. Like, why aren't you going to treat me? Well, you don't have a wound. So there's no indication. It'll just increase your chance of amputation. But then I see doctors like you, Dr. Patel, and you, Dr. Joy, that really listen to the patient. You hear what they're saying and you treat the symptoms and you provide the relief to get them out. The whole point of any of these procedures is to get them walking, and they're not going to walk if you don't relieve their symptoms, all of their symptoms, or as many as you can, right?
Absolutely. And, the ischemic rest pain is pretty severe. It's like I tell some of the family members may not understand the type of pain the patients are going through. And I explain to them and tell them, say, if I put a tourniquet on your arm and keep that on all day long, that's the kind of pain these patients are suffering, So imagine you going for a blood draw and they put the tourniquet on and left it on for 5 minutes, that really creates a lot of ischemic pain. And that's what the patients are going through. And explaining that to the family member, I think it opens up their mind to saying, these patients are really suffering. The pain is real. I find that explanation to be very accepting for the family members to understand what they're going through.
It's that same tourniquet that we could apply to the legs of the surgeon that says walk flippantly. Walk in their shoes for a day.
Exactly.
It's just a miserable existence.
Yeah, a lot of these patients can't walk. I mean, that's why, they're there for you. And patients who have wounds, they have wounds in their feet. They're told to offload and not to walk. And then here we are telling them to walk. So I've come up with a little exercise that I tell these patients who have wounds, who are not able to walk. I tell them, imagine you're driving your car and you're pressing on an accelerator pedal all the way down and then bringing your ankle back up all the way, just doing those flexion and extension moves of your ankle, while you're sitting in the doctor's office, while you're watching TV, do that 30 times every hour. That is essentially almost like walking. So you don't, have to wait to get a bicycle or anything like that. This can be done anywhere. And I had a patient who took my advice seriously. I told him to do it 30 times every hour, and he felt so good. He started getting more strength in his legs and calf and stability when he stood. So he does it 100 times an hour now, every day. So, when he's awake. So simple things like that I've learned from patients. They tell me, oh, I'm doing this, so it's helping me. And you can share those experiences with other patients as well.
Oh, that's pretty cool. And something, just since I have you both here on the line, I am dealing with so many issues with patients now coming to me. And it's ever since the New York Times article came out that these patients are having denial after denial after denial. And just as you're explaining the excruciating pain that these patients are in, and you're having to say, we can't operate on you because we need pre-authorization. And that's one of the horrible things about the Medicare Advantage plans, is that this pre-authorization sometimes can take weeks, even for patients that are being woken up at night with the worst Charlie horses that anyone could ever imagine. And you have to send them home in this unconscionable pain and wait and wait and wait. And then you have a congenital heart disease cardiologist who is saying, hey, we're not going to allow you, doctor, to use any atherectomy devices below the knee to treat this patient who has gangrene. And it must be very frustrating. And so I really was looking at developing a new series here to really focus on these insurance denials. And I'm sure each one of you has a case in your head that we could share, and to really drive home the point that we have to do something about these insurance denials. Yes, there might be a handful of doctors who might be doing too many procedures. I could probably count them on my hands. The majority of doctors are really out there trying to do what's best for these patients and listening to these patients, and not just looking at waveforms or imaging. You're really hearing the suffering that is going on with these patients. So would you each mind sharing a case that we can really drive home, the pain and the suffering that these patients are having, and with a case that in which there was a denial, and what you had to, the hoops you had to jump through to get this patient treated?
Yeah, this is a common experience, unfortunately. I mean, the amount of time that my staff spends dealing with this issue alone is ridiculous. Any number of patients, you put all the data in place. You got your exam, you got your testing, you've categorized what stage of disease they have, you've got photos of the wounds, all these things are right there in the medical record. And then we send that off to a clearinghouse where someone who does not have anything close to a medical degree, frequently not a college degree, and they're going to pass judgment on whether this patient meets their criteria or not. And there are certain words that have to be in there for each different insurance company. If you don't match those words perfectly, they're trained, the first thing they do is kick it out, make us appeal. So then we've delayed again. So any number of patients, Kim, people come in with gangrene. They can go to the hospital and go through the emergency room and go through that path, which then puts them in an environment with all kinds of other illness, all kinds of other bureaucracy and delays. Then you've got a case that's being added to a schedule that's already overrun, or a hospital that has no capacity. I mean, these are, access to care issues are hard enough without the delays that we see in insurance. And then you end up having to get on the phone and have a peer-to-peer conversation. And I'm having a conversation about a very complex, limb-threatening situation with a gynecologist who's retired, and this is now their job, is to determine what the insurance company will pay or will not pay. And that's frustrating is not the word I would use. It's well beyond that.
It is well beyond that when it comes to these patients. And then we've seen an increased number of calls to our Lifesaver hotline in the middle of the night. And so when you have to send your patient home in the middle of the night waiting for a pre-authorization from the insurance company, they're calling us to say, help, it's the middle of the night. I keep being woken up. I'm getting no sleep at all. Because of these Charlie horses, what do you do? And we have to, our team, our PAD navigators have to coach these patients through the night. Dangle your feet over the side of the bed. Okay, have a sip of tonic water. Walk, 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 walk. Okay, are you feeling a little bit better? Do you think you could lay down? Okay, and then they lay down, and 15 minutes later, we're on the phone again, and we're going through that same cycle. And I just wish some of these insurance companies, and especially I'm calling it out because I've had 2 situations just in the past week with Humana, and their system just denying. They no longer support atherectomy being used below the knee at all. They've completely eliminated its use. And when you ask why, it's, well, because, you know, there are a handful of doctors that might be using it too much. And then they cite evidence that is like from 2013 that shows that, oh, atherectomy doesn't work as well as just balloon. But why aren't doctors treating below the knee with just balloon? It's not durable, right?
Right.
So these advanced devices can actually help improve the patency.
Absolutely. I mean, these there's a lot of literature out there to prove that as well, but they stick to what's, you know, benefit for them. I mean, same thing, Dr. Joy said, we go through this all the time. You know, denials, and then we get on to peer-to-peer review, and ultimately that gets denied, and you get to the next peer with your own specialty, and that's a person finally understands what you're going through. But it requires a lot of time, you know, and office staff to, you know, set up these peer-to-peer meetings and things like that. But one of the things I did learn by talking to some of the peer-to-peer reviews, one of the medical director of the insurance company said they use these guidelines. You know, Medicare has guidelines, and these other private insurance has guidelines called MCG guidelines, and that's what they use to approve some of these procedures. And specifically, that guideline is called MCG Guideline Surgery 49H. And if you read through that, it tells you all the requirements. So, and most of these patients meet those requirements, especially patients with critical limb ischemia and wounds. So I've been including that in my reports now. You know, once I do the assessment, do the exam of the patient, and then I'll say, based on the MCG guideline, SURG-49H, you know, patient meets the criteria for peripheral artery disease with critical limb ischemia and warrants an angiogram procedure. Now, when they see that in your report, then, you know, they think twice about denying you, because now you're, you know, using their guidelines to get these approvals. So that's been a little help for me in my practice to utilize that in my consultation notes.
That's interesting. Thank you for that. Okay, final question from me, and then we just have a couple questions, and I'll let you guys get on with your Saturdays and enjoying the weekend. It's a beautiful weekend out here in California. But this is my favorite question. I always like to leave it for the end because it's a deep one. It's very meaningful, and it lets us get to know a little bit more about your character. When I was at Forbes magazine, we had a series, and it was called The 10 Minutes That Mattered, and it was the catalyst for change in your life, in your career, a moment that mattered. It could have been a show you watched. For me, it was talking, you know, getting a call from Sir Richard Branson, who said to me, you know, don't let, when I was asked to run his global startup competition, he said, and I said, I've never run a startup competition. I can't do that. And he said, don't let what you don't know and have never done before get in the way of doing something great. Sometimes it's what you don't know that could create the greatest disruption in any industry. And so just say yes and figure out how to get it done. And so that was a moment that mattered to me. And so I'm curious from your perspective, you know, what were, and this is a sponsored segment, so we're calling it the 6 minutes that mattered in your career. Was it a conversation? Was it a clip in a movie? Was it something eye-opening you saw? What was the catalyst for change that spark for some, you know, new direction in your life or in your career that had the greatest impact? Dr. Patel?
Oh, I get to go first this time. Okay. Difficult question, but there have been several instances, but I want to focus on the CLI part of my career. And when I started doing CLI work, obviously it's a learning curve to learn these, techniques and skills to, treat the tibial vessels and the pedal loop. And it takes a lot of time and dedication. And one of the patients that still I remember how important it is, this disease process to understand and knowing what the patients are going through, was a Native American patient who came with a wound on his foot. And he had interventions done somewhere else before. The wound was still not healing. And he expressed that it's very important for him to heal this wound because he's never going to have an amputation. I'm like, why you are totally against amputation? What is your reason? And he's like, if I die, I'm going to die with all my body parts intact. I don't want to die without losing any of my body parts. But besides that, he says his native Indian culture, or the belief for God, is that they believe earth is God, and the contact through God is through their feet, right? So when you touch the ground, that's where you're contacting your God. So he's like, I'm no way losing contact with my God. I want to keep all my feet intact. And that's one of my major reasons. And that led me to think that, each of us come from a different background. We may have our own reasons why we don't like amputation. But overall, I think you have to give your best. You have to learn the skill set, to do your best and not just stop at, what you can do. You have to go out there and learn these new techniques and utilize all the tools that are out there to give your best to these patients, because they all come from a different background and they all have different beliefs. And you have to accept that and make that as your priority in your practice, is to follow what the patients want.
That's a good one. Dr. Joy?
Yeah, there's maybe a two-part answer. I mean, this practice of medicine, in this particular type of medicine, because it lends itself to drama, people present with real, life-altering or life-ending issues, and we have an opportunity to impact that. And so there's this cycle of gratification that goes along with helping, and it just makes you want to help more and more and more. And it's this trick that I think God plays on us, where your outcomes and your reputation are all you have, and so you're driven to want to do your best, and it forces you to try to take on things that maybe don't look particularly possible or promising in the front end. And then you do it, the patient gets better. It's just kind of a loop that keeps feeding itself. For me, there are a series of light bulbs along the way, but on the innovation side, I remember when I was a fellow back in Pittsburgh, Pennsylvania, and I had some early innovative ideas. And I thought, you know what, that's just so obvious. Somebody else has already thought of this. Somebody must have already done this. And I sat on it. And 2 years later, it hit the market, and I just kicked myself. And so kind of from that moment forward, and going forward another 20 years, I had the pleasure of working alongside with Tom Fogarty quite a bit when I was the chief medical officer at his institute. And he would always tell the young innovators that would come in there, he's like, there's a difference between an inventor and an entrepreneur. It's one thing to think about a good idea, but unless you're going to bring it to market and help people with it, what are you doing? And so it's just kind of a different way of saying the same thing, but just motivationally, like, why would you assume that somebody else has figured this out? And how else does progress in the world happen? So act on it.
And so that's what led you to not only come up with the idea for PTAB, the minimally invasive bypass that is now FDA approved, but to also bring it to market, do
Right.
something about it.
Exactly.
Fantastic. Okay. Just want to open it up really quickly. Any other questions for the doctors before we end this wonderful conversation that we've been having with Dr. Patel and Dr. Joy?
Got one simple one. Maybe it's a little bit off, but on the axial bifemoral, have y'all ever taken them out after they've totally occluded?
No. In short, if a bypass like the one we've been talking about were to occlude, they can pretty readily be opened up again with a thrombolysis, so a clot dissolving medication, so they can be restored again. So you don't have to take them out. Generally, when stents are put in, they're put in for good. There are some exceptions in the vascular surgery realm where if they become infected, then the material needs to be removed, but that's a mess that none of us like to deal with.
Yep. And Douglas, we have Dr. Miguel Montero Baker, vascular surgeon, on tomorrow. So that's a question. Might as well ask him as well. I think that he muted. But that brought a really good question that I'd like to include in the post segment, Dr. Joy, is with every one of the procedures that a patient has, we tell the patient to make sure to ask the doctor, when this fails, what is the contingency plan? What is the contingency plan when the PTAB goes down? And that compared to a general bypass going down.
Yeah, well, thankfully that's a rare occurrence, but when it does occur, the graft can be reopened with, as I mentioned, Douglas, thrombolytic. Put a catheter in, drip a TPA, a medicine that will dissolve the blood clot, and then you maybe need to do some touch-up angioplasty. In a bigger picture, you can still do an open bypass, so it doesn't burn that bridge. Once you've done an open bypass, not too many people are excited about doing a redo. It's just a really difficult surgery. So it doesn't burn the bridge of conventional options, which is one of the other nice things about this.
And what does the data show in terms of its the patency rates? You just had 2-year data that was recently released.
Yeah, and it was there was really no fall off from 1 year, which is great. In the Detour 2 trial, the patency, we have different words we use for patency: primary assisted, secondary, kind of the overall patency. Like at the end of the 2 years, greater than 90% of these people are open. You take the same group of people and you stuff a bunch of stents in their leg, kind of the old conventional way, 10% maybe are open, maybe 0. So that's a huge shift in outcomes.
That is a
Joy,
really big shift.
I have a question, Dr. Joy. So when are these? When is this device going to be available where we can use it in an outpatient setting? From a financial point of view, because I think we see a lot of these patients initially nowadays with so many surgery centers, OBLs, and CLI patients getting treatment on an outpatient basis. I think this would be a great tool to have in our bag to treat these patients.
Yeah, agreed. I think that Endologics is tired of me asking that question for the same reasons. My guess is it'll probably still be another year. Most of these technologies, they need an early run of hospital-based experience and finances in order to get them down a path, and then they'll probably loosen up a little bit.
And Marcia, you have a question for Dr. Joy?
Yes. So these are always done in the hospital. Is that what I'm understanding?
Currently.
Okay. So my original question was how long you think they last, but I think that's what you just were discussing with the patency. Is that right?
Yes. And looking back at like the early patients that I did before this was even commercially available, I've got patients that are 15 plus years.
Wow.
Wide open. So once you get past the early stage of recovery, If the doctor puts the device in properly, if the patient takes their medication properly, and if they have follow-up ultrasound testing like they should, the long term, these things should stay open, for many, many, many years.
So if a patient is prone to restenosis, which I think is what I have, with scarring, like
Yep.
I'm an over scar, is this still a good option, or do you scar with this just like you would a stent?
Yeah, no, it's very different than a conventional stent, because in the stents that you have in your leg that are closed, it's a wire mesh. And so scar tissue has been able to grow through the meshwork of that stent all along the entire length of it. With this procedure, we're using a stent graft. The stent is covered with Gore-Tex so that scar tissue can't come through the side walls of the stents. It can only affect the top end and the bottom end. So when we do our follow-up, all we have to do is monitor by ultrasound how the top end and the bottom end are behaving. And as long as they're okay, then the rest of the graft is clean.
So is this widely available yet all over the United States?
It's getting more and more so. I know that they are opening new hospitals all the time. Certainly in your neck of the woods, Columbus does have it already.
And also one last question, and I'm so sorry and thankful that you're willing to answer. What is the recovery like compared to getting stents?
It's the same.
It is.
Yeah. So
Great.
most of our patients, even though they're done in the hospital, they go home the same day.
Wow.
Yeah.
And so
Thank
you not
you.
only have it in Columbus, but you also have it in Cleveland, right? Dr.
Right.
Sean Lyden.
Right.
Is he was part of the trial, I believe.
He was the principal investigator. Absolutely.
What about Cincinnati? I go down to the Christ Hospital. Are you familiar with that?
I'd be shocked if Christ Hospital didn't. They've been very good at adopting early technologies.
Right.
How about Denver?
Denver, absolutely. Aaron
got
Armstrong. Yeah,
That's,
Dr.
that ain't
Armstrong.
my question.
Yeah, Dr. Aaron Armstrong is actually his team
Yeah.
over there. So you named the right name when it comes to that. So Heinz is excited.
I want to ask the question to Marcia is, your stent is already occluded and you're building these collaterals. That's your natural bypass. So do you have symptoms right now, like a rest pain or claudication or anything like that? Sorry, I can't hear you. You're muted.
Sorry, I've never had rest pain and I've never had a wound, knock on wood. But I do have horrible claudication. And just in the last few days, I walk, every day. I walk a lot. But in the last few days, I've noticed my right leg is worse than my left, and it's where I have had interventions is my right leg. And I've noticed that my calf is noticeably larger on my right side. But yeah, I have claudication, and every day it's a battle. And I think I'm 65 right now. I don't know, am I going to be able to keep up with this? And as my knees and arthritis and other things happen, will I be able to keep up with it as I age? So, it's a concern, but it's nice to know there are other options maybe down the future, down the road.
I just want to I don't know if Dr. Joy had this experience with a couple of patients that I've treated with similar situation. They have an SFA occlusion, and I, go from the pedal approach to open up the SFA, but in the process, the tibial vessels are occluded, so we open that up on the way. But for some reason, we can't open up the SFA, the femoral artery that's occluded. But because these patients had a chronic occlusion for many years, they have these robust collaterals that are reconstituting, below the knee or even above the knee, the popliteal artery. And I've treated the popliteal artery and the tibial vessels, on the way trying to open up the SFA. But after I treated those vessels, somehow their rest pain goes away and their claudication goes away, because now I've treated the outflow, because you have the robust collaterals already. They're acting as your bypass. And that relieves their symptoms, and they tend to do better. I have a 1-year follow-up on one of these patients, and he's like, I'm doing great. I'm walking like you told me to, and I'm not getting any claudications, and his
So,
SFA is still blocked.
I'm confused. So now that I have reoccluded, you're saying that a possibility would be treating the tibials?
Yeah, so treating the outflow, because you have all these collaterals that I've already built, over many years. And where these collaterals connect to the artery that's open, that artery may be a little diseased or narrowed. And if you just treat that, open that up, you're getting more blood flow now, and that could be enough to relieve your symptoms, So
Yeah, that's kind of next level thinking, which not surprising from you, Dr. Patel. But yeah, people that have a good collateral source from their profunda, from their deep femoral artery, and have an SFA occlusion that, for whatever reasons, is impassable. Previous to a technology like the one we've been talking about, one option, and I've done the same thing, if they have impaired tibial artery flow, is to treat the tibials from a retrograde approach from the ankle heading north. And if you open those tibials, then they can obviously carry more blood flow to the calf and the foot, and that definitely helps people. But bigger picture now is those previously impassable lesions, those long occlusions that have been there for a long, long time, we can definitely reroute around them.
Right.
Thank you. Gives me something to think about.
Keep walking, Marcia.
Thank you. I'm trying.
I know. I appreciate
walking and
guys.
hydration. 2 miles of walking, 2 liters of water.
Well, I don't have enough water. I'm sure of that. But I do the 2 miles easy.
Yeah,
Not easy, but I do it.
2 W's. That's what I tell my patients.
Oh.
Water and walking, 2 miles and 2 liters.
How does the water play into the blood flow? I mean, just thinning it, or
just hydrating yourself, because as we get older, our mouth doesn't tell our brain we're thirsty. So if you're going to wait to be thirsty to drink water, you won't drink any water at all. So I tell my patients, get a 2-liter bottle of water, fill it in the morning, and you got to finish it by the end of the day. So
makes it kind of hard though when you're out walking, because then
yeah,
you have to go to the bathroom.
That's about 6 glasses a day. You can drink 1 glass before breakfast, 1 after breakfast, 1 before lunch, 1 after lunch, 1 before dinner, 1 after dinner. So hydration plays a very important role in peripheral artery disease. So,
well, thanks for that, because I've never heard that from from my physician or anywhere else. So well noted. Thank you.
As long as you don't have problems like congestive heart failure, when you're limited to water intake. But
Dr. Joy, can I ask you one question real quick? I appreciate your time on this. So a lot of patients have problems with SFA because of various reasons. I'm one that has radiation-induced peripheral artery disease in my leg.
Mm-hmm.
So, and Dr. Aaron is my doctor currently, and they've helped me out. Would your procedure work with something like that, with the vein and artery being somewhat more contaminated?
Yeah, individuals like yourself who have radiation-induced artery narrowing tend to be the ones that re-narrow the most. So if we're trying to fix the artery from the inside, it's really, really difficult. So these are great situations to actually bypass around it. Just that artery is not going to, they typically have a hard time staying open because they have just continued low-grade inflammation from the prior radiation. So yeah, no, it'd definitely be a possibility.
So that your new device would be a possibility, basically.
Yeah, well, it depends on where your blockages are located, but if it's superficial femoral, absolutely.
Pop and superficial femoral.
Yeah, for sure.
Cool. Thank you.
Sounds like you have a conversation with Dr. Aaron Armstrong.
Yeah, I'm getting reoccluded, so yeah, okay.
Definitely. Well, thank you so much. Dr. Joy, congratulations, champion of vascular innovation for the year 2024. We appreciate all you're doing to save life and limb and inventing new ways, because we still haven't found a cure. And so we appreciate that you're continuing to, try and help us kick the can forward as far as we can. And it means the world to us. So we appreciate you.
Thank you.
Congratulations, Dr.
Thanks, Dr.
Dr. Patel, thank you for pinch hitting today. Wonderful co-host. We'll have to tell Dr. Phillips he might he'd be in trouble because you might be replacing him. No, I'm just kidding.
No.
He's a good guy, and we hope to have you back again quite a bit. So thank you so much for donating your time. You did a great job, and we appreciate you as well. And all you do is